You are listening to Lifeboat for the White Coat podcast.
Well, thanks for joining us today on the Lifeboat for the White Coat podcast. We're with Maryal Concepcion, someone I've seen as I've traveled the country. Maryal also does the same. I forget the first time we met. Maybe it was Orlando last year, something like that. Forgive me does that sound right?
I would guess it's some
Yeah.
Rosetta Fest event over the past few years.
Okay. Yeah, awesome. And I think the last time we saw each other was at the Free Market Medical Association event in Oklahoma City. So we haven't really had a chance to talk a lot. We don't know each other well, but I think we know of each other. And certainly welcome Amy and Heather on the podcast as well. And we're very excited to hear your story, and very excited. And I think it's just one of those powerful real life stories from a physician. And you're doing so many things in this market. You're doing so many things to help others. You even have your own podcast. So welcome to our humble show. And let's start off, and maybe you can just share what you're about and maybe a little bit of your story, and then we'll go from there.
Yeah, fantastic. Thank you so much for having me, guys. I'm Maryal Concepcion. I'm a family physician by training, specifically a rural full scope family medicine physician, and I live and practice and own my own direct primary care clinic, in Northern California in a town called Arnold. I am practicing currently with my husband. He's a family physician as well, full scope, rural trained. And the two of us run our practice out of a space that we purchased last January. So I got into direct primary care after being an employed physician for nearly 6 years. I was with a system, typical, quote unquote nonprofit that seems to make a lot of profit at the end of the day type system, where the first year we came here, I want to say 11 primary care physicians and non-physician providers left the area, and the community has never restocked in terms of that access to primary care. We see a lot of people who are graduating with nurse practitioner degrees, PA degrees, coming to rural America instead of physicians, unfortunately, and we are representative of that statistic. When it comes to me learning about direct primary care, I was at a time in my career where I was getting really frustrated by the system in terms of a person without a medical degree and admin, who maybe have an MBA or not, tell me basically you need to see more people per hour. I was presented, and my husband was presented with a contract that said, if you're unable to sign this contract, well, you'll be paid based on productivity and not salary. Within this contract, there is an evergreen clause, meaning it will never be renegotiated in terms of the rates that we were being paid at, despite what CMS was doing with its rates. Exclusivity was a thing. So basically, if I worked with my medical degree for another company, the company that I worked for would own my money, which is out there for those that is a real thing. And things like, my husband and I are married. We have 2 boys. The contract read such that if they needed me at a different location, that they could just move me. And that was just untenable for me practicing. And I loved my practice. It was definitely full scope. I was able to see OB. I do not do deliveries anymore, but I have continued prenatal care throughout my post-residency career. I was able to do colonoscopies up until 2019, and I've been doing procedures this whole time, just seeing a really, good scope of full practice family medicine. But when I learned about direct primary care, it was when this contract was just getting too much to handle. And I did not want to continue on in a model like that. And so I learned about direct primary care from an orthopedic surgeon, and then proceeded to learn everything I could, which is the typical journey for those physicians who are learning about direct primary care. And I was able to stay in my rural community where there are only 45 licensed physicians in our entire county. My husband and I are the only people who you can see if you are pregnant in this county since 2015 when we moved here. And if we had not had the option to go private and go cash pay, we would not have been able to stay in this community. So the community would have lost access. And I will say, say also for those physicians, especially listening, we know that most states in the nation now have APPs, non-physician providers, nurse practitioners, and PAs able to practice without an overseeing physician. And that is indeed the case in California. It passed in 2020, it went into effect in 2023. And as a result, a week later after that, like within 7 days of that going into effect in California, the company, the nonprofit, let my husband go because they went to a non-physician model. And so the company denied access to our community to have access to a physician who would be able to see them because they went the cheap route. So I am extremely passionate about telling my physician colleagues about direct primary care. And this is why I speak nationally and every week on my podcast, My DPC Story, highlighting my fellow colleagues, my fellow physicians who are making decisions like I did to stay in their communities or to choose a community to deliver high quality access, affordable, accessible primary care.
It's funny how I was just, as you were talking, physicians and others, right? I'm not a medical background. I'm a different kind of influencer, if you will, or leader. But we refer to this as the system, and it's very natural, right? Because it's a hospital system. And just as you were thinking of that, I was like, wow, that's it's funny. But Abe Lincoln said, "If I don't laugh, I'll cry." And when we start digging into these real stories, it's reminding me of like a George Orwell book or that old movie, The Firm. Once you join the firm, everything's great at the beginning and big money, and then, but then, oh, by the way, you can't leave ever. And I'm not saying that's the case, but it just has that feel, right? Of like, we're going to lure you in. This is like the kind of the only path, and it's a very prestigious path. And congratulations, you finished your residency, and we're ready to go. And then you're like 2,500 or 3,000 patients, and you're like, oh crap, I got a lot of career left here, And so I just love the realness of your story, and I love your courage. And you're like, I don't think this is working for me, and I'm just not going to be controlled like that. I'm gonna do what I dreamed to do. And so good for you and your husband.
Yeah, thank you.
You are listening to Lifeboat for the White Coat podcast.
I'm just curious, when you were presented with all of these damaging contractual bindings, when you said something and spoke up, were they receptive, or were they just kind of like, there's nothing we can do? I mean, that had to be incredibly frustrating to not feel like you have a voice in a contract that you're supposed to sign.
Yeah. And I would say that I've never felt like I didn't have a voice. I just felt that either someone was receptive or not to it. That is, having a voice and knowing my place in life and what I stand for, thankfully, has not been an issue. When it comes to the duration of time and the experience we had with that contract. Unfortunately, we negotiated, meaning we have our lawyer, she's helping us negotiate the verbiage of the contract for a little over 2 years. And then unfortunately, what happened was the company went even more corporate than they had been, because previously we were a regional medical center. So all of the people who were the very seasoned and very skilled and very community friendly and focused people in the organization were let go, or they were moved around to different roles. And so basically you had the new crew, who is basically, the mafia for the corporation, telling us that it's either you do this or we're going to let you go. Sadly, the person who was the one who wrote me the letter, which I still have screenshots of, his uncle was a physician in San Diego, and he was a physician recruiter. And so for people, like, we're at a time when people know Star Wars and Harry Potter and the good versus evil, but these are the things that are like, so relatable when you think about how a hospital or any healthcare system is actually putting profits before patients. And so when I pressed and continued to press, the listeners on the other side changed overnight. One person had been negotiating with physicians for over 25 years and just let go because there was no longer a desire to negotiate with physicians, because at the end of the day, we are the code processors. And we really felt that at the end of at least my tenure with this corporation.
Yeah, it's just a machine. There was a woman that I worked for early on in my career, and she said, we don't live by a bumper sticker. And so when you tell this story, and when I hear this story over and over again by doctors like you, it's shocking a little bit, because every ad you see, every billboard, every soundbite is we care about our community, we care about our patients. But then to hear your stories, it's totally night and day. So I think that's what's just eye-opening for me, again, as Matt said, as like a non-medical person. So
Yeah, it is. And
thank you.
we actually just came off of our very first California focused direct primary care summit. I hosted that with colleagues who, have been in practice even over 10 years. And we were really focused on educating, our up and coming direct primary care community. But one of the questions was when we were talking about policy, because there are two bills that are DPC friendly on Capitol Hill right now, both bipartisan. Somebody asked, who's opposing direct primary care? And, technically no one is actually, having picket signs saying I oppose direct primary care. It's very bipartisan. However, what I pointed out to the person who asked was that unfortunately you have the people who are complicit in protecting the fee-for-service way of life. And those people are opposing the direct primary care movement in a way, in their own way. And to put a cherry on top, somebody told me also this weekend that there was a leader in a state branch of the American Academy of Family Practice, somebody in our country who is a leader telling specifically our colleagues to not tell residents about direct primary care, which made me very upset because as a former president of one of the AFP chapters said, it's in the policy to know that there are different types of practice in the AFP. And yet a leader is specifically saying, and this is hearsay, but it's like, I trust the person who told me this, that a particular leader in a state chapter in this country is telling another colleague of ours to not educate someone about the different options that are out there. And so that is absolutely fueling my passion as to why I speak to my fellow physicians every single week on my podcast.
Yeah, and we certainly can speculate, and you said it's hearsay, so right, there's a fair chance we know those things are happening, and then we start to question what are the motives, and why wouldn't this be such a good thing, and why wouldn't it at a minimum complement this other as an option, right? We're not here to put down anyone, we're not here to to try to make enemies, but there's just some egregious things happening, and when we hear such a good thing of DPC, right? It's a giving healthcare availability to maybe even those that don't even have insurance in many cases, and or some supplemental employer add-ons, or even in our case, part of the heartbeat of the employer plan. And so it's kind of like, why wouldn't you want this thing? So we start to question motives. We start to, usually there's money behind it, right? It's protecting the status quo, or it's protecting big money that is controlling and oppressing and bankrupting and all of those fun
How
things.
long have you had your DPC open now? How many years?
I opened Big Trees MD, that's the name of our practice, in September of 2021.
Got it. And how did you let the community know that you were available, and how did you explain it to them? I mean, how did you get the word out?
So we are very fortunate in that we had practiced in this community. I was in my role at the community clinic for nearly 6 years, and my husband was in, I think, past 8 years. And so with us being the only full scope family medicines in the entire county since 2015, pretty much our community knew who we were. I mean, we're in a very small town, around 4,000 people. The nearest Walmart is 45 minutes away. The nearest ER is 45 minutes away. The nearest trauma and NICU is an hour and a half away. And so we are very remote. When it comes to, I would say, the first 80% of patients who joined in the first couple of months, these were people who said, I don't actually know what this is, but I need to make sure that I don't lose you as my physician. And so we are very fortunate in that our patients knew us, and even within the admin pulls and demands of fee for service, they knew that we were trying to do our best in that role. And so they took a chance financially as well as, access wise, because once you basically leave the system, it's very hard to even get back. I mean, even the nurse practitioner who we used to work with, their panel is not, perpetually open. And so that is who joined our practice in terms of getting the word out. I mean, we are so small that I have had a patient literally shout from our steps, and this is in our old clinic, but as people were driving from the post office home, the post office is catty corner to our old office. Why aren't you part of this practice? Like literally that is our like live walking billboard in Arnold, California, for which I'm so grateful because our patients have been the way that we've been continuing to grow. We actually just literally as of last Friday, we were just awarded an honor by the Chamber of Commerce for being one of the best businesses in the entire county. And when we are nimble and when we have our autonomy, we're able to deliver personalized and community-based needs. So we work with public health where a lot of people won't even think about accessing or collaborating like that because they can't. They're under a contract with a corporation.
You are listening to Lifeboat for the White Coat podcast.
Right. Thank you for answering that, because even though our audience is a lot of physicians, we also have an audience of people that are curious about where things are going in this paradigm shift. And we're just trying to help nudge it forward a little bit faster, because when I started talking with these folks, with Matt and Heather, my eyes were opened and I was ticked off. I mean, we all know from a consumer perspective and a patient perspective, we all know something is going wrong. There's something odd that I can't understand, but I need this care. So I'm just going to move forward. And every time we talk to a different doctor from a patient perspective, the more I learn and the more the audience learns about truly the options that we do have that were never really shown, because it's always the big thumb is pushing us down or pushing them down. So I appreciate you sharing that. And what a cool story. I mean, that you did start out in a system at a clinic, and then your patients just followed you. I love that. And they said, I don't know what it is, but I'm going to move forward because I love you. So, and we people do business with people, and a doctor patient relationship is a business, right? And you do business with people that you like and make you feel good. And obviously you did a great job, and congratulations on that. If you were to share something from, I guess, the new kids leaving medical school that are ready to sort of go out on their own and have the two paths or the three paths, whatever they want to do. What perspective do you feel that you actually got a lot more educated working in the medical system first and then jumping? Or do you believe that, they should skip that altogether? I mean, what is your philosophy there?
Yeah, well, from the perspective of physician versus non-physician care, this is why I interview my fellow colleagues, because these are people who are actually trained enough to know what is normal and what is not. I mean, literally, that is what we go to residency for. So we have 15,000 plus hours of training. A nurse practitioner or a PA can get an online degree, work 4,600 hours of quote unquote supervised care, and then magically become a doctor in the state of California for the nurse practitioners. I speak to the physicians out there
That's
because
the first time I've ever heard that. I mean,
yes,
this is literally the first time I've ever heard that. So this is like,
yes,
are you kidding me? And majority of the
yes,
time that I was childbearing age, I would always get put with the physician's assistant, always. And I
yeah,
always was curious and why, but thank you for sharing that. Thank you.
yes. And this is also why, just a side note, but a very culturally relevant note, especially in these days, I will not use the word provider. Provider, if you literally Google provider, NIH, and Nazi, you literally will learn a lot about the word provider and its history. I am not a provider. I am a physician, and then there's non-physician providers. So that is the terminology I tell my colleagues, especially those who are in training, because I want to make sure that they know that the difference between a physician and a non physician provider is very much rooted in the sheer hours that we are with patients to learn what is normal and what is not normal. At the very end of the day, that is what helps me, especially as a rural physician, say there is something not okay with this. I need to figure this out quickly. I need to transfer you to the emergency room, call 911, or I can actually take care of this. Let's watch it a little bit. That is what a physician-led practice is able to do because of the hours of training. Apart from that, when it comes to, could we skip residency altogether just when it comes to the billing? My thing is this, is that yes, there are residents. I even have a series of doctors, 2 family medicine, 1 internal medicine, and 1 pediatrician who I've interviewed annually since they left residency and opened before they graduated residency, all of these 4 doctors. And that, this is their 5th year that's going to be updated as to their 5 years into practice already. But what I will say is I have a very different appreciation of what the system is and is not when it comes to my experience in residency and life after fee-for-service medicine. Do you need that trauma? I don't necessarily think you need all of that trauma. I think you start getting that in medical school, whether you like it or not, because that is where you start learning with patients your 3rd and 4th year of medical school. But I do think that when it comes to relatability, when it comes to empathy, when you're graduating medical school, I think the youngest person in our class is 29. At 29, I had no kids. I had, my own bills. I was not married. I didn't have, well, I think I got married at the tail end of 29. But generally to say, if you have exposure to anything, the more exposure you have to things in general, you have more things to pull from when you're being empathetic with a person because you have no idea what they're going to be talking about or what their experience is in life. And so for me, more experience it helps me be a better doctor. But that doesn't say that you can't do it and that you're not going to be empathetic or able to relate. But for me, I just feel that the more experience you have in anything, you're going to be with more tools in your tool belt.
It's interesting, and you have your own podcast and right hear these stories all the time, but you're not the first person that's told us about the words and how big insurance is almost monetized people, right? So, and it's a really fascinating point. I had never differentiated, right, the use of provider. I try to avoid that as well, although it still comes out because that's such a common term. But then you say it doesn't differentiate between physician and non-physician. That's the first that hit me. There's a physician in Georgia, and I'm sure you know her, that was her last straw where she just asked to have physician on the name by the door and they wouldn't do it. And we see words like, right, so provider and then producer, even for an advisor or broker, to me is demeaning. Producer. So I think words do matter. I mean, and but we see the reflection. It's almost like their motive comes out, like let's monetize everything, including people and titles, and just be a robot and go do it. And there are many, including me, and it sounds like yourself and us on this call, right? Where I'm just not able to be a robot. I've got to have purpose and meaning, and I gotta care about people. I can't.
And I think it also speaks to the fact that when you're, there's people who say the system isn't broken, the system is built exactly for the people who it benefits, which I do believe. But when it comes to, for example, and I have my favorite picture that I took in my clinic, and I say that in the most facetious sense. Happy Doctor's Day. Whether your doctor is a chiropractor, a physical therapist, or a nurse practitioner, happy Doctor's Day. And so it's literally a campaign also, in my opinion, to water down what a physician is, because when like my clinic and my community that I worked at, the clinic that I worked at and in my community, when you no longer have access to a physician, but they're still celebrating Doctor's Day, the person doesn't necessarily think about, did that person wear a white coat? They must be a doctor. The person is just assuming that they are having some physician engagement or oversight at a clinic, especially if they do not know that the law passed to change that in 2020.
Is that law across the United States, or is it California only?
No, so AB 890, I believe, is the bill that was passed in 2020 and went into effect January of 2023, but that is a state specific.
Got
Yeah, and I think so. Like in Wisconsin, we have a law that a non-doctor, so a PA or an NP, can open their own clinic, but they must have doctor oversight, physician oversight. And so I think, and some of those are doing well. And I think your point, right? But there needs to be a very clear, and I've had other doctors, MDs, share this with me, and I don't know how you feel about that, but let's at least differentiate. Let's at least be very clear about someone who went right 15,000 plus hours and then 5,000 or so hours or less. There's a big difference between that. And I think it's almost a matter of disrespect or a matter of respecting the physician. So it's important that we clarify that. And I'm not
And
sure how all the state's laws on those are.
yeah, it definitely every state is not there yet, but I will say beyond just the respect part of it, like, you know, I don't wear a white coat. I'm not like, oh, I'm a doctor and you're not. But my big thing is it absolutely is related to patient safety. That is the massive problem when it comes to you have proof. The Hattiesburg study showed after I think it was over a decade in studying. I believe Kaiser did a study is when you have a non-physician provider led team, the cost of care goes up, the amount of, you know, use of the emergency room, the bad outcomes. I mean, all of these things are shown to be worse with excuse me, outcomes are shown to be worse with a non-physician provider um, way of practicing and a non-physician provider leading the medical practice.
You are listening to Lifeboat for the White Coat podcast.
We see in the system model today too, probably for many reasons, but primary care can act as a funnel in a good way or a bad way, depending on how we use it. But we certainly see NPs and PAs referring more, right? So you give a very short amount of time because you have a huge patient panel, and then referring a lot more. And I think so they can employ that person for less, and that person is doing a great job and doing their best, but they can employ that person for less, but then get more referrals because they have to, right? Because they don't have the training. So that suits that system well, because most of the money is made on the referral to the specialist, not solving the issues in primary care as we often do with DPC, and eliminate the even very need for a referral.
Yeah.
So.
And as you talk about employers, I mean, we see a huge shift, as you very well know, of employers going towards self-funded plans and away from BUCA plans exclusively. And I will say that, you know, when it comes to non-physician provider needing to refer more often, or even the physicians who are basically told, you know, you have 8 to 15 minutes per visit, and then they have no time to spend with their patient that they have to refer, the outcomes are going to be worse in a lot of cases, cardiac, GI, et cetera, when you are delaying care because you're unable to take care of it at the clinic. And so to me, it's like this equates to higher bills for and utilization for employers who are, you know, using this type of plan.
Yeah, I think it's rushed care is never great care, right? I mean, for those that maybe don't understand some of the medical dynamics, I always use a simple analogy is, right, you give your mechanic 15 minutes per car, and that at the end of that time, the time's up. How many cars are actually going to get fixed? How frustrated is that mechanic going to be? And then so there's a lot more coming back because they're never fixed, and so the brokenness continues. And I don't know if that's a fair analogy, and I don't want to minimize medical, but it's the same thought of, all right, go. You get no time to do what you do best, and we'll just rush everything through, and nothing, you know, very few things get fixed, and patients aren't happy, doctors aren't happy, and we just slow down and do it right. But there's less money in that, and but you know, on that point, and I'll be careful, there's less money in that. But you know, I know most independent physicians, the ones that have gotten through the starting point, and they tend to make more than they did in some of them, at least in the hospital system.
When it comes to the financial side of things, I do think that there is a little bit of difference between primary care, specifically pediatric care, internal medicine, family medicine and internal medicine peds versus specialty care that are not those specialties. I do think that it definitely even depends on the specialty, because direct primary care as a business model can be adapted to many people. I mean, we even have Surgery Center of Oklahoma and Wellbridge Surgical Center. So you can use the direct primary care business model in different specialties. However, when it comes to the membership-based clinics, it's definitely more easy and palatable in primary care. You do have some specialties like rheumatology, dermatology, cardiology. Those are, dealing with a lot of chronic disease as well. And so I think that when a person has a disease that is, it deserves to be managed by an expert, whether that is an expert in their primary care office or their specialty office, or a collaboration of both of those offices. The direct primary care business model can work, but when it comes to finances, I think it's really it's multifactorial. It's one, starting with the end in mind is a very powerful thing. Like, what is your financial need that you have to be able to pay your bills, pay whatever you need to at the end of the month. And then working from there, I think, is really an intelligent way to go about things, especially as my fear is that we're on a looming recession and at the time of this recording. And when it comes to, how do you future proof? With a recession where you don't know what's going to happen. I have some of my friends that we joke about, like, what are you buying in a zombie apocalypse fashion right now? Like gloves, things that won't expire, because we don't know how much things will be. We live in California. We don't know if gas is going to go to $7 soon. It's already past 4, so per gallon. So when it comes to the finances, I definitely would say that it gets a little simplistic when it comes to what is if you're in a membership model, and I'm speaking to this specifically, if you're in a amount per member per month times 12 months, and you take away your overhead, and those numbers are making it work so that you can pay your bills and potentially hire staff, take a salary, etc., that's how one can, work those numbers in terms of, is it going to be bringing in income more so than a fee for service, or is it something that you might need a side gig, quote unquote, as you build up your practice? Or are you financially able to just say, like, if I have 0 patients on day 1, I will be okay financially? So that's definitely part of how DPC is very individualized to the physician practicing, no matter what their specialty is. But I definitely would say that the math is a heck of a lot more simple than what is the current reimbursement code rate for the CMS to say that, the 9921 da 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 is this. And are you a primary care doctor? Are you a specialist doctor billing this code? So the system is completely opposite when it comes to transparency, and when it comes to literally being able to, use your cell phone calculator to figure out, what is the forecast of my medical practice if I were to take members, or if I were to charge per visit like some specialists do.
Great information, and I think you're one of the veterans nationally right on this topic. You literally have your own podcast about docs sharing their story. And as we're kind of approaching time, so we can see if we have any other burning questions, I do have a home run question that I always like to ask, and I would love to hear your view on this. But as we mentioned, many of the viewers, at least part of the audience for this, is physicians who are doing independent practice and maybe looking to grow, and especially those that are maybe caught in the system and are frustrated or about to enter the system as residents and that kind of thing. What advice would you have for those folks based on what you've done and what you've learned?
I definitely would say, and this is where, I am still very frustrated by the fact that there is a physician out there telling another physician to not tell people about direct primary care. You went to medical school to become a physician to take care of other people. When we are in a system like that, what is not focused on or highlighted or called out, so to speak, is the fact that we are the good. If a system does not have a physician, and yes, they're replacing us with nurse practitioners and PAs to do the coding, okay. But at the end of the day, we are the value proposition. And that's why recruiters will spend, 2-3 years to try to recruit us to their position. When it comes to what I would say to my colleagues out there is, try to learn as much as you can to protect your autonomous way of practicing, whether you're doing that in fee for service, if there's a way to renegotiate your contract and you want more autonomy, you want to be able to protect your ability to do procedures, the time you have with patients, depending on your specialty, great, try that. But also just be educated on how to protect autonomous practice when you're not relying on insurance for reimbursement. There are so many ways to do that. My podcast, I've interviewed almost 300 physicians on my podcast. There are conferences throughout the year. We just had our California Direct Primary Care Conference. There are so many books out there. There are other podcasts. And just knowing that physician entrepreneurship is a thing that you do not need an MBA for. Those are really powerful things that I wish I would have heard in medical school and residency. And they might not have clicked for me as much as they do now. But I say that because this is, again, thinking towards an exit strategy, knowing business acumen at all will help you recognize that you as a physician actually has value. And so when someone asks you, how much are you worth per hour? You don't shy away like a wallflower. You can say, oh, a plumber costs $275 to come and evaluate my issue. As a physician, my hourly rate is, and you can fill in the blank. But that is something that, I challenge, especially residents and medical students, to think about, like, has anyone actually told you that you have value? Because I will tell you every single second of the day that I am talking with you that you have value in what you do. This is what you went to be a professional in, is to be a physician, to take care of other people.
Great stuff. I'm not especially a Dr. Phil fan. I'm not even sure he's a real doctor, right? You can call yourself doctor, but one of my favorite things that he does is he'll look at someone on the show, or right, he's a counselor, and he'll say, how's that working for you? And that always makes me laugh. And I think I even put that in my book, right? But we start to question just our reality, and right, we question those that are trustworthy, and we start in those that are untrustworthy. And we're not trying to label people or peg them for a mistake, but it's pretty clear to see who's trustworthy and who's not. So we've definitely got to be careful who we listen to. There are a lot of people out there just spouting off a lot of things, but we look behind the scenes at their motives, where their money's coming from. And often when they're going against what's obviously good, we can start to question that. So I think just be careful, right, of just partner with trustworthy people, and good things will happen. So certainly thank you for your time today. Your time is extremely valuable. I would certainly love to keep in touch. And how can people reach out to you? How can they see your podcast? Maybe some contact information you could share.
Yeah, and thank you guys so much for having me. I'm always happy to spread the word about direct primary care. MyDPCstory.com is the landing page for our website. Is our website for the podcast. The podcast is on all podcast platforms. It airs every Sunday as a new episode, and that's pretty much my main contact page in terms of where you can find other physician stories as well. I have created a patient-facing set of content. The content hasn't come out yet, but I have published the mapper where patients out there can find a direct primary care practice that is physician-led. So that website is caringdirectly.com. And then if you are a physician or a benefits advisor or somebody in the ecosystem of direct primary care, I created the direct primary care directory. So the DPCdirectory.com is where basically you can list your services if you're a consultant, if you do marketing, if you do benefits advising. And it's a place where, just like Yelp, people in our community can leave their testimonials so that a person can exactly read, like, oh, I actually know this physician in Raleigh who worked with this person who I'm reading about. I know this physician and I trust them well. That helps me find someone who's trustworthy in this space. And then, when it comes to my practice, bigtreesmd.com is my actual practice here in Northern California.
You are a busy woman. That is amazing. Well, thank you so much for joining us on Lifeboat for the White Coat podcast. For those of you that are listening, that are looking for a job or looking to maybe join your first independent, we do have a website called whitecoatlifeboat.com, and it is independent practice positions that are listed there. Or if you are an independent practice looking for somebody, feel free to join and upload your job description. Thank you again, Maryal. We really appreciate you being on our podcast.
Thank you guys.
This concludes this episode of Lifeboat for the White Coat podcast. Please make sure you visit whitecoatlifeboat.com.